All right. Good morning. This is our second talk in the wastewater section, and we're really pleased to have Dr. Marlene Wolfe with us this morning. Marlene's an assistant professor in environmental health science at Emory University. She's an environmental microbiologist, environmental engineer, and epidemiologist, and has really been at the forefront of doing wastewater-based epidemiology since the start of the pandemic. So I'm excited to welcome Marlene, and I'll let you get started. Thank you.
Awesome. Thank you so much for having me. I'm excited to talk today, and I can't believe, I don't know if we've all been hearing this a lot lately, but I can't believe it's been 4 years now that we've been doing this wastewater work specifically for COVID, and 4 years since the start of the pandemic. I hope you all can see my slides. It does come up properly. Okay, great. But yeah, it has in fact now been 4 years since we started doing this work. All of us, including Erin and her group and so many others across the country, started very early at the beginning of the pandemic on monitoring SARS-CoV-2 and wastewater. And I know she talked about that last week. And so hopefully I'm not going to repeat too much of what she talked about, but I want to kind of expand and talk about going beyond COVID and expanding targets for wastewater monitoring, building from the research on those new targets to then bringing those into practice and working between academics like myself and public health. So let me tell you first a little bit about kind of the perspective that I come from, and then I'll get into some specifics about expanding targets. So a lot of the work that I've done and a lot of the kind of perspective that I bring to this conversation right now is based on this program that I have been running with my colleague Allie Boehm at Stanford for, 3.5 years about now almost, because we started this in October and November of 2020. And we have started in the Bay Area and then slowly expanded across the country so that this program, which we call Wastewater Scan, now has 191 sites across 41 states in the US. And our goal with this program has been to use consistent methods for monitoring infectious disease and wastewater for really two kind of main focuses. One is to expand wastewater science in terms of pushing the envelope on methods and on new targets that we can detect in wastewater and making meaning of that. And then also to support public health response and do some of the translational science that helps us to kind of bring this work to have impact in public health, right? So those are the two main goals of this program, which is, a research program, an academic-led program, but at a scale that I think is a little bit unusual for academics, which is super fun and also at times a little bit overwhelming, but it has been a really great opportunity. So like I said, Allie at Stanford and myself are kind of the directors of this program, and then we don't have our students process all of these samples by any means. We have a partner, Verily, that we contract to run all of these samples that we get 3 times a week from these sites. National League of Cities is another partner that kind of supports translation of this work for cities. And then all of our local partners, which includes municipal public works and wastewater and state and local public health. We've worked really closely with the Georgia DPH throughout kind of the time that we've had wastewater scan sites in Georgia, which is about 1.5 years now, I think. And so yeah, that's been an amazing partnership, and I'm excited to talk a little bit about that. Let's see, click. Okay. These are just for some context, I understand it's March now, that's my bad. These are the kind of the current targets that we are running in the wastewater scan program to give you kind of an idea of what we're working towards as we talk about expanding the targets that we're monitoring. We've got a number of different respiratory viruses. So we began with SARS-CoV-2 and then expanded to influenza and RSV. We also have human metapneumovirus, parainfluenza, and EVD68. For enteric pathogens, right now we're monitoring norovirus G2 and rotavirus in all of the samples that we're testing. And then we have a little bit of a soup of other pathogens that we've put into another category, Mpox, hepatitis A, and Candida auris. We also run a couple controls, pepper mild mottle virus and bovine coronavirus as an endogenous and exogenous control on all of our samples. So we've grown, as you can see, quite a ways from just working with COVID to, again, really having a focus on how can we build the evidence base for more things to test in wastewater. What does this work for and what does it maybe not work for? And then this is a little bit of that timeline just to show you how we've kind of slowly added things over time. We began in March 2020 with just work on COVID. In November 2020, we started doing this program prospectively, where we actually were getting samples from sites and turning the data around in real time for those original sites in the program. We had samples every day, and we turned the data around within 24 hours. For the national, expansion, we have the samples shipped 3 times a week, and then that data gets turned around within 48 hours. And it goes on our website so that it's publicly available right away as soon as the data is available. So at the beginning, this really was a little bit of an experiment to say, okay, if we can make this data available as quickly as possible, knowing with some of the formative research that everyone in the field had done that there was a relationship between those measurements in wastewater and cases, what could public health do with this? Because they were very stretched thin at the time, as everyone, you all are still stretched thin. But especially in November of 2020, we were like, let's just throw it out there and see, what we can do to make use of this with the partners in the Bay Area and California that we were working with at the beginning. And then after that, starting in 2021, we really started expanding into more targets. So we started looking at SARS-CoV-2 variants. We started influenza A and RSV in January of 2022. We started expanding around the country. We added Mpox, human metapneumovirus, influenza B, and then a bunch of new targets we added just in, I forgot a date, September of 2023 is when we added those targets. So this is where we're at now, and sort of the perspective that I bring to talk about this topic of expanding targets. Specifically in Georgia, we have 8 sites for wastewater scan that are in Georgia. The majority are in Atlanta. So if we zoom in, kind of these are all the sites that are basically encompassing a lot of Fulton County. We've worked closely with Georgia DPH colleagues to get input on plans, to work together to provide evidence for new targets and their use, and think about what may be useful for the state to use in terms of data and to pursue in terms of the state wastewater monitoring program, which I know you're going to hear more about, and then also interpreting and using data for public health. So we just meet regularly to talk about, how these different data streams are useful and how they can be used for public health action. What we've found is that this collaboration has been really wonderful for allowing for a flexible approach to evaluating new ideas, right? Because we are producing a lot of data in real time, it's real data that we can really work with together for public health, but at the same time, we are an academic research program. And so we're able to sort of use our funding and use our flexibility as academics to pursue things that may not work out. And so that provides a really powerful opportunity for us to evaluate something, work together on it, and then for the DPH to look at it and say, well, what do we want to do as public health practitioners based on that research? So it's been a very fruitful partnership because of that. Okay, so here's kind of the 4 main things that I want to go through. First is key considerations for collaborating to add new targets, then creating a systematic process for adding new targets. Then I'll give you a few examples of the process and introducing some new targets, and then I want to talk just briefly about communicating and sharing results, since that's a big part of what we're doing with our program right now. So first, key considerations. So I know that we've had a little bit of background on this, but I always find it helpful to mention that, of course, the wastewater is providing insights on infectious diseases. So the amount of genetic material in wastewater from these infectious disease agents is related to the number of people infected pretty consistently for many diseases. So that's what we're starting to see, that it's, it's amazing how we've been able to expand beyond sort of the original imagination of this really being something that was for enteric pathogens to realizing that this would work great for SARS-CoV-2 because there's so much fecal shedding, to then realizing that why not other respiratory viruses, why not other types of pathogens, and that in fact, over and over and over again, we do see this close relationship between the number of people infected and the amount of the genetic material in wastewater. Because when people have infectious diseases, they shed secretions that contain that pathogen, right? In different ways. But the great news is that it's not just your toilet that goes to the sewer, right? It's also sinks, showers, toilets, et cetera. So you brush your teeth, you take a shower, you go to the bathroom, all of those contributions are ending up down the drain. And so that composite biological sample that is, again, not even just urine and feces, can really provide insights about a whole community. And I really believe that one of the things that is powerful about this and makes it really complementary to a lot of the systems that we have for infectious disease surveillance is that it includes a lot of groups who may otherwise not have as much access to healthcare systems. Now, of course, we know also that access to sanitary systems is not universal, but if we're thinking about the approaches as complementary, there's a lot of ways which we're kind of broadening the inclusiveness of who is being monitored and who is being included in our infectious outbreak surveillance by adding wastewater into the mix. As I mentioned, many pathogens are shed such that they appear in wastewater. And one of the things that's wonderful about this is that the same process can be used for many targets from the same sample. One of the things that's been a lot of fun about this work is that as we work with different DPHs around the country and with CDC, we're working with different divisions all the time because there's respiratory disease, but then we're also working with hospital-acquired infections. We're also working with vector-borne disease. We're also working with enterics. And so there are a lot of different pillars that wastewater ends up crossing because even with that one sample, we can make measurements for a bunch of things at the same time without having to take another sample, or kind of the logistics of obtaining the material can be the same. And so that also allows for really great partnerships for research and development and supports quick introduction because we don't have to change the majority of the process in order to introduce a new target. We have to be very careful about the changes we're making at that last analytical step, but the majority of the process can remain the same. And so that really gets us a lot of the way towards what we are going to have to do to implement monitoring for a new disease. So how do we choose? There are a few things that we look at in particular. One, is there a compelling use case for tracking the target in wastewater? We don't want to be just throwing spaghetti against a wall and see what sticks. We want to be intentional about figuring out what are diseases where we think that there's a gap in surveillance and that it would really be helpful to have additional information from a wastewater sample, whether that has to do with the biology of the disease or whether it has to do with some of the systems that we have for surveillance. There are a lot of different reasons that, a target could be a good one. Another is, maybe is it vaccine preventable? What are the actions that you might take if you had more information from wastewater? So is there a compelling use case? And this is a lot of conversations with practitioners, right, to understand kind of where are the gaps? Where do you wish you had more information? Number two is super important, is the target of interest shed into wastewater reliably and in detectable quantities? And for the most part, it's amazing how much we've seen that, if people are infected with something infectious, they do very frequently shed it in ways that ends up in wastewater, even if that's not something that is part of the transmission that we would expect to happen. So an example is that we've done some work on dengue. We would not expect at all for dengue to be infectious in wastewater. Shedding and secretions that end up in wastewater is not a part of the transmission because it is a mosquito-borne disease, but yet you still do have shedding of that virus in people who are infected. And so it's something that we are able to pick up in wastewater. So we want to make sure we have some evidence that this is possible, but it's much more possible than you might think for a lot of diseases that wouldn't originally be kind of on your list of likely candidates. And then the third is, can an assay be adapted or designed to specifically and sensitively detect the target in wastewater? So we want to make sure that we can detect it, that our test is specific enough that we know that we're really targeting that particular infectious agent rather than other things that are similar or might cross-react, because there's a lot in wastewater, and so we want to make sure anything that could cross-react is not cross-reacting with those assays, and we want to make sure it's as sensitive as it can be, because most of these targets are going to be relatively rare in wastewater for things that are not kind of abundantly shed in urine and feces, like norovirus. Norovirus is very abundant in wastewater, but a lot of the things that we're looking at, dengue, or even some of the respiratory viruses like influenza and RSV, where most of the shedding is coming more from the respiratory secretions, probably than in the gut. Those levels are lower than what we see with COVID or norovirus. So we want to have very sensitive methods to detect. Okay, so determining priority targets. So, I'm sorry, I took this slide from another presentation about our work with California and the Center of Excellence, so it misreferences California. But California and Georgia are the two primary partners that we have for wastewater scan, because Allie and myself are based in California and Georgia, respectively. So we work with the California Center of Excellence for the National Wastewater Surveillance System, and we are sort of formally working with CDC in California in that capacity. But we do many of the similar activities about prioritization and thinking through how do we balance these targets and prioritize with our colleagues in Georgia. So some of the things that we look at for priorities are diseases with significant surveillance gaps. So that's many respiratory viruses. It's also a lot of enteric viruses as well. Diseases that are vaccine preventable. So rotavirus is a good example of something we're monitoring right now in wastewater that is vaccine preventable, an enteric virus. Diseases that are rare and high consequence. So Mpox, Candida auris, sort of an imagination that a future disease X is something that we could monitor in wastewater. And diseases where the underlying epidemiology is less well known. So something like norovirus, where again, we don't necessarily have as much clinical data on norovirus as we might like to have. Then again, evidence for shedding. So shedding data is rare for many diseases. So this actually can be very difficult to do. So a lot of the time what we're just looking for is to confirm, like to the extent that we can, that there is shedding. The quantitative shedding data is pretty rare. And this is an area where we really need more data and we need more research. If we're able to get more quantitative data on what kind of shedding load distributions are for different pathogens in different secretions that are likely to contribute to wastewater, that will really help us to do better modeling of what these measurements in wastewater mean in terms of disease outcomes in the community. So that's something that we're really hoping for more of in the future, and I know many people are working on. But even without that quantitative information, we can look to see, is shedding confirmed? Is that happening in a way that ends up in wastewater? And we can still interpret the data kind of against itself over time, looking at levels over time. And then finally, can an assay be adapted? So the basic process that we go through for identifying an assay is first to check for a previously developed clinical or environmental assay. And if one exists, try to adapt it. And then if one doesn't exist, then we'll try to design a new assay that will target a region of the pathogen's genome that is going to be specific enough for use in wastewater. Either way, we'll align that assay with recent clinical sequences to kind of confirm its specificity. We'll test for specificity in silico, and then we'll also test for sensitivity and specificity in vitro against a panel of other viruses and background. So once we have done all that, we implement this process for evaluating and adding targets. So the laboratory process that we use allows for testing of a number of diverse targets and also for multiplexing. So again, like I said, from the point of collection to almost the very end of the process, we can use basically the same system and then make changes just at the end to allow for a lot of flexibility. So after samples have been collected and sent to the lab, the first step that happens is a pre-analytical processing, which is a dewatering and resuspending of solids. We use the solids in wastewater for the wastewater scan program because many of the targets that we analyze for are sort of preferentially move into the solids. And so they're naturally more concentrated in the solids. And then in case of something like Candida auris, that pathogen is so large that it actually sort of is a solid according to a lot of our definitions of solids. So we use the solids, and what we'll do is we'll pellet down that sample, whether it was collected from kind of the influent headworks of a plant or within the sewer network or in a primary settling tank. We'll centrifuge that sample to settle it down so we get a thick pellet of solids, and then we'll resuspend those solids in a solution and do nucleic acid extraction from that resuspension. After nucleic acid extraction, we use droplet digital PCR, and we're allowed, they allow us, the overlords of PCR, we are able to multiplex targets and controls in each plate. And so we run a couple plates, but we are able to multiplex within each one to test for all the targets that we're testing for from that same sample that we receive in the lab. So this is kind of the overview of how we apply this process. So first we select the new target. After we've done these steps, we've determined it to be a priority, shedding is likely, and target sequences are specific to the pathogen. We've identified our assay, and we've confirmed that it's specific and sensitive in silico. Then we procure the primers and probes and positive control material. This can be the most difficult part in the process sometimes because it can take a while to get the materials that you need. And then we'll test again for assays, specificity and sensitivity in the lab. Specificity will test against other viruses, and sensitivity will test a positive control in the background of other viruses. And then we'll apply the completed assay retrospectively. So typically what we'll do is we'll look for a time and a place where it makes sense for us to test for the target that we're interested in, using some sort of known data and conversations with colleagues in public health to determine what kind of a good look back would be. And because we have been doing this program for years now, we have a pretty significant biobank of samples. And so, sometimes we will prospectively collect new samples for looking at a new target, but we also have the opportunity to look back and say, oh, well, now that we're thinking about this particular disease, actually there was an outbreak in this location at this time. We have some samples from that time period. We can go back and look at those. So that has been an incredible resource for us. And we'll then apply that completed assay retrospectively at the selected locations. Then we'll take those results and we'll compare that wastewater data to relevant clinical data. The quality and availability of that clinical data really depends, of course, on what disease outcomes we're talking about, but we're really looking for kind of best case scenarios where we have the best possible information that we can get on clinical outcomes. Often, though, we do have to take that with a grain of salt and understand that neither of these methods is the gold standard for understanding what, disease has been in the community. And so we'll want to make comparisons and observe how they relate, both to sort of validate what the wastewater data is showing us to an extent, but also to be able to describe, when we use both of these data streams, what is the relationship between the two and how are they complementary to each other. And then if that all has gone well, and we think that there is a good relationship here, it seems like this is useful, the data is giving us useful information, then we'll pilot prospective application of testing, and we will observe the performance of the testing, gather feedback from partners, work to see how this is actually kind of performing in real time. And then if that's going well, then it might be something that we add into kind of the larger program and start measuring on all of the samples that we're receiving. So it is a very systematic process and a fairly lengthy process, but it's also something that we have been able to do pretty quickly when necessary, when kind of push comes to shove, especially if you kind of like get your primers and probes on time and things like that. You know, if ordering goes smoothly, that goes a long way towards making this process go quickly. But we were able to use basically this exact process in the summer of 2022 to start monitoring for Mpox within about 2 weeks of when the first case appeared in the United States. So if there's the motivation and again, the arrival of materials on time, this process can be pretty quick. Again, this is just a list of now kind of where we're at with the targets. Okay, so examples of integrating some new targets. So I'm just going to run through a few examples of things that we're doing right now and kind of how we arrived at the process of including them in the program. So RSV was the first thing that we expanded to outside of COVID. We designed new assays for RSV and tested their sensitivity and specificity in wastewater. We analyzed wastewater from pre-outbreak and outbreak periods, and this was actually the very beginning of when RSV started to come back. This is statewide RSV positivity rate in California. These dates are from 2021. And this is when we first started to see RSV again after all respiratory viruses had really been very suppressed for quite a while at the start of COVID. And on the bottom here, you see the statewide RSV positivity rate. And then on the top here, you see these are measurements from one site in the Bay Area of RSV and wastewater in terms of copies per gram. So we were non-detect for quite a while, and then the levels started to rise around the same time we started to see an increase in positivity rate. These two are not obviously a perfect match. This is statewide, and this is covers about 95% of Santa Clara County, so a very large county, but you know, the geographic match is not there, but we're using this as a general indicator of kind of does what we're seeing in the clinical data align with what we're seeing in wastewater. And there was a strong association between the wastewater and the positivity rates observed. And our public health partners were very interested in the data and wanted to kind of see more of it for future use. And so we added RSV monitoring to our programs in January of 2022. So it's been a little over 2 years now that we have been measuring RSV in all of the samples for the program. We also just published this paper like 2 weeks ago looking at RSV nucleic acids across the United States. And so I didn't want to get into all of that because I could talk for a long time about this one specific paper. But I could put the link in the chat, and this is cool because what we're looking at here is really kind of what is the relationship between across the whole country, what we're seeing in the wastewater levels for RSV, and then some of the state and regional level outcomes that we typically look at for RSV surveillance, like positivity rate and hospitalizations. So we're really, again, trying to take this from proof of concept to then how does this really relate to the other tools that we use in public health and how can they be complementary to each other. Influenza is very much the same story. So we started working with CDC primers and probes for influenza. We tested sensitivity and specificity in wastewater, and we had a little bit of a different and unique opportunity for influenza where we were able to look at 2 outbreaks that had pretty good case findings. So rather than looking at that positivity rate and having to kind of compare a wide geographic scale to more specific wastewater outcomes. There were 2 outbreaks. One was in Ann Arbor, and so we were able to look at the incidence rate of influenza because there was a CDC investigation into that outbreak because it was one of the first influenza outbreaks in the country after COVID had started. So again, this is at the end of 2021. And then there also was an outbreak on the Stanford campus, and this was largely among athletes. And so there was a lot of case finding that was done to test among athletes. So really like pretty good case ascertainment, which is a little bit difficult and unusual. And we were able to make these comparisons between the incidence rates on the bottom here to the wastewater data on the top. And so we saw that there was a strong association between the wastewater values and the incidence rates. Again, people were very interested in continuing to see how useful can this data be. And so we added this as well in January 2022. And this paper, which is from last year, is very similar to that paper on RSV that I just mentioned, where again, we're looking at, now that we've been running this for a while in all of these sites across the country, you know, what kind of relationship is there between this national, regional, state level data and some of those more traditional outcomes that we're used to using for respiratory virus surveillance. EVD68 is a little bit different, right? This is a much rarer respiratory disease, one that is often undetected. It's a new emerging infection, but it can have severe outcomes. It can result in acute flaccid myelitis. So it's something that we're very interested in being aware of when there are outbreaks that are happening. So we selected an EVD68 primer and probe set, tested specificity and sensitivity. We went back retrospectively and analyzed wastewater over a 2-year period. And what you can see in these 2 locations, San Jose, and this is in San Francisco, is that for the most part, for most of the study period, over 2 years, the results were non-detect in wastewater. And then we had this big spike. And you can imagine all of us looking at the data as this came in, because we ran this kind of in order in like 2-week chunks of samples. And it was like, okay, more non-detect, more non-detect, more non-detect. And then as this curve started to fill in, we were like, oh my gosh, wow, that just came out of nowhere. And we were working with the California Department of Public Health on this. And so we talked to them, and they had, you know, planned to share some of this data with us on cases. And so we reached out to them and said, you know, okay, here's the results. What was happening? What happened? You know, and they were like, wow, actually, there is an exact spike of cases that is right at that time. So this was really exciting to see. And one thing that was pretty interesting about this is that this is, again, the California EVD68 cases overall as a whole. And then these are 2 specific areas in San Francisco and San Jose. And there actually were not any of these cases that were reported that were in either of these sewer sheds. So this is really good evidence to us that, yes, there was in fact EVD68 circulating at this time. However, we don't believe, because we know that it's difficult, that all of the EVD68 cases were able to be ascertained and counted, right? And so what this really suggests to us is that wastewater is showing us that there is disease circulation in communities where it may actually not be recorded in other ways. We don't doubt these results. You know, we feel very confident that this does represent that there were cases in the area, because we know that there were cases in the surrounding area that were recorded at that time. But it likely represents, you know, our ability to identify things that are not being identified in that area through case finding, because there weren't actually any cases in the sewer shed at that time. So yeah, so EVD68 has been a really exciting addition, and we just started monitoring it everywhere in September of last year. And the last thing I'll touch on is just something that is wildly different for fun. I mentioned this already. We've done some work on dengue. So dengue is not part of our like wastewater scan monitoring program, because it doesn't really make sense for us to monitor dengue in every single location. And in Iowa, you know, it doesn't make sense for us to monitor dengue right now. So we haven't included this in the program everywhere. But we did work really closely with Miami-Dade County to monitor dengue. They have the highest rates of dengue in the United States outside of Puerto Rico on an annual basis. And so we looked at 4 different assays for 4 dengue serotypes, did all of that background to kind of make sure that the assays were going to work well in wastewater. And then this represents testing over 14 weeks in summer 2023. We had 3 different sites in Miami. And then we compared this to the Florida and Miami-Dade case data on dengue, including both travel cases and locally acquired cases. Now, the levels were really low. The concentrations that we observed, as you can see in this kind of middle panel here, those concentrations in the positive samples were pretty low. So as a rare target, low levels. However, we were able to consistently detect some dengue serotype 3 at all 3 sites in Miami. And what we found was only dengue serotype 3, and that this was during a time period when cases were regularly identified. Now, we're not able to really observe a relationship between the concentrations and the number of cases. Again, these are sporadic detections at this point, but this was a really exciting proof of concept, and there's been really strong interest from our public health colleagues because there are so many difficulties associated with traditional surveillance for dengue, and it can be very difficult to do case finding. And in fact, during this time period in Miami, there were, we know, locally acquired cases, and we see these positive tests in wastewater, but pooled mosquito testing actually had not yielded any positives. And so this could be, another tool in the tool belt to kind of keep track of dengue outbreaks, especially in areas where we don't maybe typically see them or where we're concerned about expansion. Okay, so I'm gonna almost wrap up here. Adding new tools into practice. So now that we're doing all these things, we're doing them regularly, how do we add them into practice? And like I mentioned, we are posting the data as soon as it's available. How do we do that well and in good collaboration? So early and often communication has been really important to hear preferences and feedback from partners before launch. Like my motto about this project is never surprise anyone with anything. I always want to make sure that we have thoroughly heard all of the feedback and have worked with everybody so that everyone is prepared before we start putting new data out there. And that includes things like making fact sheets. So when we started monitoring Mpox and when we started monitoring Candida auris, we had fact sheets that we worked with different public health partners to produce to be able to share and say, here's what we know and here's how we think this data should be interpreted. And that information could be used internally and shared with leadership and also used to kind of help answer questions from the public, because sometimes there are questions from the public about some of this work. So that preparation of talking points and fact sheets has been really important, as well as releasing research results rapidly. So if we are putting something out in our program that's based on research that we've done as the foundation for saying this is reasonable to do, this can be useful, this is real, we want that research to be available and published, or at least pre-printed, so that people can reference it and look at it and judge the details. And then also support to and collaboration with public health to examine and interpret data after launch. So we will spend a lot of time looking at, after something new has launched, the incoming data on a regular basis to interpret and kind of make sure that things are going smoothly, and also think about, again, what it means when we actually have that data to work with, which is really exciting. So for that communicating and sharing results, this is our website. So our data dashboard is data.wastewaterscan.org. This is what it looks like when you land there. And you can see that we have this panel on the side with all the different pathogens that we're monitoring, and we have assigned categories to different pathogens. And so this is based on both what the change has been over time, if there's been a significant increase or decrease in concentrations, and also the level compared to retrospective data for the past year. So are the concentrations high, or in the kind of the upper third of what we've measured for the past year, or are they low in the bottom third or in the middle? And so then we'll make a determination about a category to just sort of help give context and help people understand, what does that number mean? The number itself for these measurements isn't meaningful in the way that a number of cases might be meaningful to people, especially the general public, who are very used to looking at numbers of cases throughout COVID. And so we really try to kind of put that category on there, not to say that there's a particular action or outcome that should be associated with it, because every jurisdiction is going to think of that differently and have different actions that they'll take, but to help kind of guide the interpretation. And then if you click on this little chart icon, you will get to a chart builder page where you can create graphs that look like this one. This is SARS-CoV-2 in wastewater in Georgia since July 2022. And you can see the bold black line is the aggregated overall concentration across the 8 sites that we have. And then all of the colored dots are the measurements from different individual sites. So we have 3 times a week samples from most sites. We have 12 disease targets. And again, once it gets to the lab, we have a 48-hour turnaround time until the data is on the dashboard. So that means it's usually pretty timely, but of course it does depend on the samples. It depends on shipping. Shipping has always been a sort of like thorn in our side throughout the whole since 2020 for all of us, right? So yeah, depends on shipping, but the data is there pretty quickly. And then we also have all of these other ways, and we're continuing to do more and more to sort of share the information, communicate, explain, contextualize, etc. We do weekly data updates on social media. We're kind of like all over social media right now because Twitter's a mess, and so we've got the same stuff going on Twitter and Blue Sky and Threads. We're on LinkedIn, so we post data updates kind of on all of those platforms. And then my team at Emory in particular works on managing this Instagram account, so Wastewater Scan on Instagram. And again, we have data updates, info on new publications. We do kind of deep dives on different pathogens that we're testing for. So we're trying to, engage people in that way. We also have fact sheets that we've started producing. So this is about that paper that I mentioned on using wastewater for influenza season characteristics. So we have this new fact sheet that we put out that's based on that paper and some of the other work that's been done. And then we have another one on RSV that we're going to have available soon. So we want to make more of these to kind of help make this research accessible. And then we also have regular newsletters that we send out. So this is a little screenshot of one of our newsletters. We send a newsletter every few weeks that gives just an overview of the program and lots of details also on kind of what our recent data is showing us. So takeaways. Public health and academic partnerships provide amazing opportunities to quickly respond to new concerns by implementing wastewater testing. Allows us to do that research to see, will this be useful before anyone has to commit to this is useful and we're going to go all in. And so that has been a really great opportunity. It's really important that our laboratory procedures are fit for new targets. And if so, that will allow for minimal changes in sample handling and processing, which enables us to expand so much to all these different targets. So an example is that using the solids has allowed us to pivot to Candida auris, where you really kind of need to use the solids or include the solids at least to test. So we're always thinking about how can we kind of make these methods as pathogen agnostic as possible while also getting very sensitive information about the specific pathogens that we're testing for. And then a structured process of choosing and developing new targets is important to be able to provide rapid response with a strong evidence base. And so we really try to kind of stick to some of the systems that we've set for ourselves to have structure to that process and the evidence that we can produce to support introducing a new target. And that's it. Thank you so much. This is my email address, marlene.wolfe@emory.edu. This is many, but not all of the people in the lab and otherwise who make this happen with the samples every day. And I want to especially say thank you to our Georgia Public Health colleagues and all of the utilities here in Georgia who have made it so rewarding for me to do this work here, to be able to have these really strong, close partnerships in my backyard and have that kind of local collaboration has been really, really wonderful. I'm relatively new to Georgia. I've been here almost 3 years now. And so to be able to form those partnerships and have people who are willing to work closely and excited to collaborate has been just absolutely wonderful. So thank you.